So we have Dr. Vivian Lee, who is the CEO at University of Utah Health Systems and the Dean of School of Medicine. We have Dr. Kathy Hempstead, who is the Senior Program Officer for the Robert Wood Johnson Foundation. And we have Dr. Kimberlydawn Wisdom, who is the Senior Vice President of Community Health and Equity and Chief Wellness Officer at the Henry Ford Health System. So three, I think, wonderful perspectives on this issue of transparency, and I think we'll add variation now based on your presentation.
Good afternoon, everyone. It's a real pleasure to be here, and I'd like to thank the organizers for inviting me. In my 5 minutes, I'd like to tell you two brief stories at the University of Utah, very much along the lines of what Dr. McCary just talked about in terms of transparency motivating change. And then after those two stories, just like to invite you to learn more. The first story is about transparency in patient satisfaction, and this is a story that started a few years ago at the University of Utah. Like many of our organizations, we struggled with patient satisfaction, access times, long waits, disgruntled employees, and we decided to tackle that by starting with Press Ganey surveys for all of our patient encounters. We see about 1 million patients a year in our healthcare system. And we asked these patients the typical kinds of questions in terms of the friendliness and courtesy of our staff, the clarity of instructions, the wait time, and so on. And we fed those data back to individual providers, and then eventually their supervisors, and eventually up to my level. The kind of scorecards are shown here. So here's an example of a provider who joined the University of Utah about the same time that I did. And so in his scorecard, lots of red, not perfect performance, but with this feedback, with some help, over time he rapidly improved his patient satisfaction scores. Now last year, about a year ago, we decided to take it one step farther, along Dr. McCary's lines, taking a lesson from TripAdvisor and Amazon. And we decided to post these online. So if you go to our website, and you use the usual feature that most websites have, a Find a Doctor tool, and you click on that, you can look up any physician, any provider in our system. We have about 1,200 employees, 1,200 physicians. And so, for example, if I type in the name of one of our pancreatic surgeons, Courtney Scaife, you get the typical bio, address, how to contact her, how to make an appointment. But additionally, you see here in this upper right-hand corner, the very familiar 5 stars. Those are the data taken straight from the Press Ganey surveys from all of the patient encounters. You can only provide data if you're a patient into this system. And as you can see below, in addition to the 4.7 out of 5 stars, you can actually see the actual rating. So for each of the questions that we ask, you can see the rating that she received for the last year from her patients. And below, we have all the patient comments, everything from very kind and informative, excellent physician, to we won't be seeing the doctor again, she was great, but we needed someone closer to home. And so we've posted those. About a year ago, we faced a little bit of resistance from some of our providers, you might imagine. But we always said, if you were the patient, what would you feel? How would you like to have access to these data? And of course, these are much more reliable and accurate than some of the other online tools that are popping up. Not surprisingly, this impact of transparency on our overall system-wide patient satisfaction scores was pretty dramatic. So you can see we started the overall patient satisfaction effort a few years back, and we saw system-wide a progressive improvement in our national percentiles. And then once we posted online, we saw another incremental step when we went online live with our patient satisfaction scores. The second story that I want to briefly mention is transparency and value, which is a works in progress now and something that really complements the patient satisfaction work. And I don't need to emphasize to you the importance of value in everything that we're talking about. And I also call attention to that same Lee and Porter article just last month in Harvard Business Review, and I particularly call out the importance of cost. For a field in which high cost is an overarching problem, the absence of accurate cost information in healthcare is nothing short of astounding. And what they're referring to here is not the charge issue, but really not knowing our costs, how much of it costs us to provide care, how much a unit of labor is, how much a supply is, how much a test is. And if we actually know our costing, this unlocks a whole cascade of opportunities such as process improvement, better organization of care, and new reimbursement approaches that will accelerate the pace of innovation and value creation. So using the same principles that we developed for our patient satisfaction, we decided to dig deeply into value with an initiative we refer to as value-driven outcomes. And the most challenging part is understanding our costs. So, for example, for any of our procedures, we did the same analysis. Let's take appendectomies. We worked out all the professional costing components, which arose from 5 different departments, and the facility components, which originated from 16 different org charts. And with that kind of data, we now have a tool that reviews all of the value. This is transparency internally only, where on the y-axis we have outcomes that are quality-based. On the x-axis we have cost. The size of each bubble is the volume for each provider, and you can see these 3 providers have consistent quality but different costs. And here on my second to last slide, you can see for all of our hip replacement surgeons, this is transparency internally driving cost and quality, driving the value equation. So when we put our 8 or 9 orthopedic surgeons in a room together and say, why, Dr. G, is your cost for a hip 3 times the cost of Dr. E? And we can drill down to the supplies, the pharmacy, the imaging, and so on, components of it. This is a significant driver of change for us. And for us, this really epitomizes how transparency can drive the value initiatives that we need to undertake. And I just mentioned that in order to really motivate the change and affect the change, we need to equip our physicians and administrators with the tools. So we've undergone a system-wide lean transformation training with our business school, and I encourage you to think about that kind of partnership.
Hello, everybody. I'm really glad to be here, and I've really enjoyed the theme of this panel, which is transparency in the triple aim, because it occurred to me that it really ties together a lot of the most exciting things that are happening in our field and a lot of things that we're doing at the Foundation. So I wanted to take a couple of minutes and just talk about some things that the Foundation is doing in the area of transparency. Of course, we were working in transparency before anybody called it transparency, and I think that we could have been at Marty's talk where there were only 2 people. One of them could have been from the Foundation, because for many, many years we've been working in the area of quality reporting and patient safety. We've worked with Leapfrog, National Quality Forum, and the Aligning Forces for Quality program, of course, for years and years and years has worked with these regional alliances to try to encourage more in the ambulatory setting than in the hospital setting to create public reporting about provider quality and healthcare quality. And we've learned a lot from that project, and one of the things we've learned is that it's very hard to organize that kind of activity in the ambulatory setting. And another thing that we've learned is that it's not necessarily easy to get patients and consumers to pay attention to that information. If it's not relevant, if it's too complicated, if it has too much detail in it that doesn't really pertain to them. So one of the things we're trying to learn more about is how to create quality information that's really meaningful to consumers. We've partnered with some interesting organizations to learn more about how to relate to consumers, one of which, conveniently, Consumer Reports, which is actually really great at communicating complicated issues about choice and making decisions to consumers. So we've worked with them on a lot of sort of regional issues of the magazine that provide quality information about doctors in particular regions. And we also partner with Consumer Reports in talking about some issues related to overuse. We work with a program called Choosing Wisely, which you may or may not have heard of, but that is a program that's really designed to get providers and patients to be more aware of thinking about whether certain kinds of procedures and tests are really necessary, and that there's the potential for, for injury as well as waste when we use procedures that are not really necessary. So that's another way that we're partnering with Consumer Reports and really trying to reach consumers and get them interested in some of these issues. A lot of transparency activities geared at hospitals. And Marty talks a lot about hospitals, and there's the most quality reporting is based at hospitals, and hospitals are sort of large targets, and that's where a lot of the money is in healthcare. They're already highly regulated. So it's no surprise that a lot of transparency activity is geared at hospitals. hospitals. But I think it's even more challenging and just as important in the ambulatory care setting, where there's sort of less structure and practices can be organized in a lot of different ways. And I think we're going to see, and I know Marty didn't really talk about this today, but in his book he talks a lot about some of the sort of transformational things that really have to happen in the clinic to kind of enhance customer experience. And I think this is particularly important in ambulatory care. And we're working on a project called Open Notes, and we're working on another very kind of high concept project called Flip the Clinic, where we're really trying to think about what are ways to make a customer experience in the ambulatory care setting better. And right now, I think everybody that works in the industry or is a patient knows that the customer experience in medicine really lags behind all other industries. So I think, especially in the ambulatory care setting, we're going to see an increased attention to the quality of the customer experience, and it's going to be measured, and it's going to be important for providers. A lot of the work that we're doing really recently, and this is what I wanted to talk about in my 1 minute left, has to do with price transparency. And this is something where the foundation has gotten really active lately. We've been really interested in this increased supply of price data in the system, whether it's from an all-payer claims data system or whether it is from these different multi-payer claim systems that exist privately and are used by different people. And we've started to really wonder, what is the impact that they have on price, of course, and utilization? Early reports suggested that they maybe weren't going to have that much of an impact. And Marty talked a lot about variation, and of course, sort of the goal of putting price data out there is to reduce variation. But again, just drawing the lesson from the quality experience, one of the early lessons we learned is that when we put price data out there and consumers aren't really interested in it because it's not contextualized to their own benefit design and their own experience, what we find instead is sometimes providers look at it and use it to reduce variation kind of the wrong way by increasing prices. So some of the early experiences with sort of consumer websites with price data were not really that successful. But the last thing I just want to talk about really quickly is something that we've been involved with pretty recently, which is sponsoring a challenge related to the CMS release of ChargeMaster data. And that's a challenge that is for developers of tools and applications, and the idea is for them to make tools and applications that will allow people to use the price data and connect it with other important kinds of data like quality data. And I'll just say two things because I know I'm out of time. One is that we heard so many comments from people, to the basic effect of, oh, who cares about that data? That's just ChargeMaster data. Nobody pays those prices, so why does anybody care about ChargeMaster data? And at first, I sort of thought that myself a little bit, but as time went on, it was a real learning experience for me because what I realized was there was an enormous interest in the variation in these prices. And that data set was downloaded more than 400,000 times, which you might or might not have known, but that's a lot of times. We had a record number of entries into this challenge and people frantically trying to build applications that use this data that allegedly nobody cares about. But what it said to me is that even though consumers don't pay charges, and maybe really hardly anybody pays charges, when people look at that variation in price that doesn't seem to have anything to do with quality, they know that something's wrong, and that's a sign of a market that's inefficient. And they know that there's a really good chance that the prices that they are paying are not efficient prices. And when prices are not efficient, they're usually not good for consumers. So I'm out of time, but I just wanted to sort of leave you with that thought. And the winners of our challenge are going to be announced at a transparency summit that the Foundation's actually hosting in early December in Washington, I think December 2nd through the 4th. And then the winners will be on the website, and you can take a look at what they have created. Thank you.
Good afternoon, everyone. I very so much appreciate Marty's presentation, and it was very provocative, but also it helps, especially when you read the book, to understand how, as we can benchmark our healthcare industry with other industries that do so well with transparency and public reporting, that it will just hopefully drive the quality of healthcare in this country to an even greater level. I'm going to give a perspective from Henry Ford Health System, and Henry Ford Health System is a large integrated healthcare organization, $4.2 billion company, actually a Baldrige Award-winning company, which I'll address a bit in terms of transparency and the triple aim. Has a major 5 hospitals and 23,000 employees, 30 ambulatory care sites. It has a major training education program, a $60 million per year research effort, a health plan. So a very, very comprehensive organization. But also it serves a very diverse community, and that's in part what I'm going to share about when we talk about variation. It serves a population of largely, has a large contingent of African Americans, Latina. It has the second largest contingent of Arab Americans outside of the Middle East. So, and also our medical group is comprised of a very diverse group of physicians speaking over 60 different languages. So that kind of sets the stage. But I think one aspect that was very key in terms of the doctor's presentation relates to culture and how important culture is, and I would underscore that multiple times, because setting the culture of the ability to be transparent and the ability to be open and just. And I do want to say our CEO, Nancy Schlichting, is one that has very much defined and promoted a culture of transparency and justice. And let me just give you a couple of examples of that before I move to the elements that relate to diversity. Very much at Henry Ford Health System, a just culture is promoted where individuals can feel that they can be open and transparent if things don't go quite as well as would be expected. Also a very team-focused approach, and I know the doctor mentions quite a bit in his book the importance of having teams and the ability to share among teams, the ability to, as you talked about in your story related to the polyp, to know that you have other team members that you can call on in terms of addressing quality. Involvement of leadership in rounding. We actually have an element where executive leaders go to various clinic sites and business units, various hospitals, and address quality by conducting rounding on Wednesday afternoons. And today is Tuesday, right? So we'll have rounding tomorrow. Also, in terms of our employee engagement elements, we've included, I know Kathy Oswald is here, our Chief Health Resources Executive Officer, that where part of that engagement survey we've included safety elements to help us understand and have our employees be able to talk about and assess quality. But what I do want to mention in terms of the triple aim and transparency is the importance of when we understand that we serve such a diverse community, and when we look at the literature locally as well as nationally, we see that significant health disparities exist. So when we talk about variation, it begs the question, well, how does that play out in communities that are diverse? And how, when we look at health inequities and moving more toward health and healthcare equity. Over the last 3 years at Henry Ford Health System, we have actually had conducted a healthcare equity campaign, and this slide is actually in your packet. And very much we've linked the equity proposition to the quality proposition and say very much that quality and equity are two sides of the same coin. So if we're going to have quality, we need to have equity, and we need to decrease that variation among that population. So the healthcare equity campaign focused on helping to ensure that the staff at our health system, including the researchers, not only understand but practice to eliminate, decrease, and ultimately eliminate those healthcare disparities, and that they work toward healthcare equity. So on the clinical side, we've had a campaign that's focused on doing assessments among our staff in terms of clinical treatment, collecting race, ethnicity, and primary language data through a self-reported mechanism, and also reporting this information in our quality, what we call our blue book, and stratify that information by race and ethnicity so that we can understand fully how to close that variation among a diverse population. Also, on the consumer side, and working very closely with our Greater Detroit Area Health Council, they are a consortium of players, plans, and providers in order to provide public reporting of our medical group in terms of transparency. So there's a website called My Care Compare where data is reported publicly in terms of care that we're providing to patients on various initiatives. Also, in closing, I do want to share that we have very much a regional effort when we look at quality, the quality proposition, and understanding how, as a region, and we can provide the highest quality of care and how we can share best practices among other health systems within that region. So I look forward to our question and answer period. Thank you.
Does the TripAdvisor ranking, can we measure whether it's actually impacted our bottom line? And that's a really great question. We don't know. We started posting our online scores about a year ago. And what's challenging about it is that we have anecdotal responses that it's, of course, very well received. Patients are very excited about it, very satisfied in having that. But there actually are no other systems in our vicinity that actually have posted their scores online. So we don't have that, that environment to sort of level out a playing field in terms of who has higher scores and who has lower patient satisfaction scores, because we are, as far as I know, the first to post them online. So I think we'll have to track that over time. It's a great question. I think in this case, it doesn't really cost us anything to do it. And so what we are seeing overall is the overall drive towards improved responsiveness to patient needs is probably in and of itself makes the whole investment, it makes the whole initiative worthwhile. Particularly, I would say, around access. Because for every extra patient that we're able to feed through our system, that obviously hits our bottom line, regardless of any other aspect of it.
Thank you. Other questions?
So that's a great question. So the question is really about how do we define outcomes? And so for us with this tool, we find it's a very powerful tool. So of course our baseline is to use HCAHPS, to use CMS, to use all the quality metrics that we're getting, you know, that we already have established. But at the same time, what we've asked our teams to do is to come up with their own indices. So we have a perfect care index, which we require them to use the minimum of the quality metrics that we know that we're accountable for. But in addition, they're adding on additional metrics that they feel are important, including in our orthopedics group, a big emphasis on patient-reported outcomes.
Is there any data that would indicate whether patients who are reviewing a doctor or a hospital might be reluctant to be too critical on the basis that they may be back there or they may be back at the doctor's office?
Who'd like to try to answer that? Kathy, any comments?
I don't know of any evidence. That's a really interesting question. I think rating doctors is really in its infancy. So I think at some point that question will be answerable.
Kimberly, any thoughts about that in terms of the equity in care?
In terms of, sometimes patients are a bit concerned in some of the research that we've done that if doctors are rated a certain way, or if they downgrade a provider, that will impact their ultimate care. So there's some reluctance to reporting some of that because the sense is that there may be the downside of actually being adversely impacted by it.
There is one category that we don't take very seriously, which is for the pain clinic. So pain clinic, we don't actually look for 100% patient satisfaction because of the behavior. But overall, we don't see that there's any negative.
So the question is the impact of implementation science, data, and impact on culture.
As a physician, providers don't go into healthcare in order to not provide the highest quality, do the very best they can for their patients. So I think it's very important, and actually Vivian and I were having a bit of conversation about this during lunch. It's important to do all that we can, even in the spirit of transparency, to ensure that we help providers move along the continuum in a favorable way, but not harm providers, because it's not about harming the profession. So I think it's important to take a staged approach, and much of the research that we've done, whether it's breast cancer screening rates or those sorts of things, when we show the providers the data, that is an immediate step toward them beginning to change behavior, because once they see how their outcomes are compared to their colleagues, that's a tremendous motivator. But taking a staged approach where you help share the data with them first,
give opportunity to change. Oftentimes change and impact systems, because sometimes it's not just the provider, it's the system within which they're working, and then move toward more of a public transparency. So maybe Vivian, you can talk a bit more about that, but sort of a staged approach and getting to where you need to go, and not just moving from, we have data and now let's publicly report it. Because like I said, no provider wants to move in that, has the intentions of harming people, but the data is very helpful in knowing how best to move forward.
Thank you.
One quick comment about that. So I think that's a really great question, because from our perspective, and I don't know what it's like in your organizations, but the data are actually sometimes the easy part. The change is the hard part. So for us, as I mentioned on one of my last slides, one critical part of our strategy, especially on the cost and the quality transparency piece, is to equip our, especially physicians, I have to say our physicians are kind of the last holdout, in terms of having the tools to manage change. And so starting about a year ago, we partnered with our business school to bring cohorts of physicians and their teams through lean management. How many of you are familiar with lean management? Most of you, right? So if I asked a physician group, actually the inverse number would raise their hands. And we said instead, tell us about those problems that are just driving you crazy. Forget about these data, forget about any of that, but just think about, when you're late, 2 hours late at the end of the day, the OR turnaround time, the colonoscopy room turnaround time, whatever it is, whatever drives you crazy. And we're going to take you through a lean process to teach you how to manage that change, to get that variability down, because it is usually a variability issue, and to give you those skills. And then once you have those skills, now we're going to start showing you these data and put these problems into your hands to try to figure out how to navigate the change. So for us, the data are important in motivating the change, but the skills to actually make the change happen are probably even more important for us.
Great. Kathy, I was thinking about this concept of variation, and I think RWJ is in the community health arena in a very big way, as far as triple aim, advancing health, improving the experience of care, reducing per capita costs. Is there data out there that you're seeing that shows variation on a community population health basis that the foundation is beginning to use, or are we just on the front edge of that?
Well, there's a couple of things. One of our grantees, of course, is the Dartmouth Atlas, so they've done a lot to document variation in hospital referral regions throughout the country, and they're actually just about to start a big project on surgical care that might be interesting to a lot of people here, where they're going to talk about variations in cost and quality and outcomes, And I imagine some of the issues that Marty brought up in his book about robotic surgery, and some of the issues around the use of technology is going to come. Of course, my husband got a robotic surgery, and I felt so proud. And then I went to a conference the next week, and Mark Pauly was there saying, oh, that's the biggest waste, robotic surgery, it doesn't help. And so it's funny, the technology wars. I mean, there's people that say they're really wasteful, and people say they're really a good use of resources. But at the foundation, we have some other things like the county health rankings. You might be familiar with those. Sure. They are really based on population health metrics. I think it's much, much harder to change counties' health than it is to maybe, not that I'm saying it's easy, but to change performance metrics within a healthcare facility. So I think the county health rankings do gather a lot of attention, and policymakers are interested, and they kind of see, what is driving burden for different kinds of chronic conditions in their region, but it's not necessarily obvious
Sure.
for them what to do about it. But yeah, we do look at variations in population health metrics a lot.
Terrific. Marty, we're out of time, but I want to give you the last word. Any comments?
Well, when I asked the CEO at Cleveland Clinic, why do your patient satisfaction scores go up every year, his answer was that we doctors are the most competitive creatures on the face of the planet. And when there's a level playing field, they will outperform any goal put in front of them. And I think that's the challenge with transparency. How do you have metrics that are fair?
Great. Give a big round of applause to Marty and the panel. Thank you. Andy?